Hello, my name is Corey Langer. I'm professor of medicine at the Abramson Cancer Center in the University of Pennsylvania in Philadelphia, and it's my privilege to discuss two game-changing presentations at ASCo in head and neck oncology. The first was an update of CheckMate 141, a phase 3 trial comparing nivolumab to investigator's choice chemotherapy for squamous cell carcinoma of the head and neck. This was a critical phase 3 trial in recurrent metastatic squamous cell carcinoma of the head and neck, the oral cavity, pharynx, and larynx, and individuals who had disease progression either on or within 6 months of prior platinum-based therapy. Patients were randomized to nivolumab 3 mg per kg intravenously every 2 weeks, one of the standard doses, to a dealer's choice, either methotrexate 40 milligrams per meter squared weekly, docetaxel 30 milligrams per meter squared weekly, or standard cetuximab, all agents that are used in this setting. The randomization was 2-to-1, and the demographics of the individuals enrolled on this study were fairly typical of the advanced head and neck population. Of note, well over half had received 2 or more prior cancer therapy regimens. It should also be noted amongst those tested that slightly more than half were P16 positive. Nivolumab was clearly superior. There were more patients remaining on treatment at the time of assessment. Overall survival was significantly improved at 7.5 months compared to 5.1 months median for investigator's choice, with a hazard ratio of 0.70 and a p-value of 0.01. And one-year survival rates were more than double, from 16% to 36%. Many of us would argue that this is a major game changer in the field of therapeutic oncology, particularly for head and neck cancer. For the first time, we have phase 3 data that show an advantage, specifically a survival advantage, for immunotherapy compared to standard monoclonal antibody and chemotherapy in the second-line setting. Of note, when you look at the survival analysis, these benefits were realized in virtually every demographic group. It's intriguing, PFS was not better, which implies that there may be 2 separate populations, one with a long-term survival advantage and another one where chemotherapy may do just as well, or even a little bit better. And I think it's important as time goes on to figure that out. And there are tools that are being used, specifically PD-L1 testing suggests that those who register positive for the target antigen on the cell surface have a much greater advantage. For those who are PD-L1 1% or higher, the survival advantage results in a hazard ratio of 0.55, and the curves diverge markedly, whereas there's very little separation for those who have no PD-L1 activity. The second paper by Josh Baumel looked specifically at pembrolizumab, another PD-1 inhibitor, in patients who had received both platinum and cetuximab, so a more heavily pretreated population. This was a straightforward single-arm phase 2 study in advanced head and neck carcinoma with 228 patients screened, nearly 200 receiving at least 1 dose or more of pembrolizumab, and mature minimum follow-up of 6 months or more in roughly half that population, 92 patients overall. Again, the demographics were fairly standard for this population. There were no unusual toxicities for this agent, for that matter, for nivolumab in the phase 3 trial beyond those already seen. Those who were PD-L1 positive, the response rate was 17%. It was a bit lower in those who were PD-L1 negative, 8%. And the responses, when they occurred, were often quite durable. Because the majority of folks did not have a systemic response, PFS, again, was relatively low at 2.1 months, but median survival equaled or exceeded that seen for nivolumab in the randomized phase 3 trial at 8 months. Again, no control arm, so this was not randomized, and we don't have a comparison to older second and third line agents. But these 2 drugs together, nivolumab and now pembrolizumab, have both shown activity and resulted in survival rates that have previously not been observed in head and neck cancer. And it's only a matter of time, I feel, before these agents will be formally approved in head and neck cancer and will become standard second-line therapy or third-line therapy in those already exposed to platinum and cetuximab. The big question, of course, is whether they will be grafted onto first-line regimens and whether they will make an important change in that setting. Thank you very much for your attention.